Hey there, welcome to Cumberland Conversations. This is the place where we talk about the issues that matter most to you, your patients, and your community. We're diving into real conversations with real people, sharing insights you can actually use. Let's get the conversation started. Hey everybody, it's Rob Lillard, Medical Director of the Cumberland Pediatric Foundation, welcoming you back to another episode of Cumberland Conversations, our podcast where we discuss everything that's going on in the world of pediatrics. And today we are doing a journal club with a little bit of a different take. We're going to talk about training the next generation of pediatricians. And it's an appropriate time to talk about this because we are recording this on July 1st, when all the new interns are starting fresh and having a great time today. So I am happy to be joined by Dr. Rebecca Swan, who is Vice Chair of Education for the Department of Pediatrics at Vanderbilt University Medical Center, and Jessica Garnea. Did I say that right?
Yes.
Okay, wonderful. Who is not working at the hospital today because you have graduated and you are off into the world of primary care here in Nashville, correct?
Exactly.
At Academy Children's
Correct.
Clinic is where you'll be. So we are looking forward to a conversation about where we are in today's training and workforce development for pediatrics in the future. So we pulled several articles, and we're just going to walk through those and have a conversation about some of the challenges and where some of the positive things in the future training of pediatricians lies. And we want to start with an article that was in the November 2025 issue of Pediatrics, titled The Community Preceptor Crisis and a Call to Action. We have seen this, especially in our community, as a little bit more of a challenge to find preceptors. And but the article makes it very clear, I think, that they are an essential part, especially having experience in the pediatric office, because there are some things that you just can't replicate in a hospital system. I think, Rebecca, would you agree with that?
Absolutely. I think there's definitely differences in both what occurs in an academic-based continuity clinic, but certainly in order to see what actually goes on in a community setting, there's no better experience than actually working with a community preceptor.
Right. And did you have that opportunity?
I
Jessica?
did,
Okay,
yes.
Tell me about your...
We have our private practice elective that we can choose to go into. And with those, I was able to shadow an Academy Children's Clinic and get more of a feel of what it's like to be in one of the more community settings and how that runs different than our hospital-based clinic. I was really happy and excited to see how much more continuity there was able to be and just how close a lot of the patients were with their providers, and really a very close-knit family feel that was highlighted in the community clinic in particular.
Yeah, and I agree with that. I think I still remember back even when I was in medical school at UAB, we had the opportunity, we went out in the community, and I worked in a small town in a family practice, and obviously I didn't know I was going to do pediatrics at the time, but I saw primary care as a whole new light, because it was just, you were everything to the patients, but also the standing in the community. I remember going to the lunch, in the small town diner and things like that. Everybody just knew who everyone it was in that office. And so it was that sense of reward and meaning that I think kind of led me down that path. And so, but the challenge is now, obviously the world has changed a lot. I've done this for a long time, and what pediatrics was then and what it is now is totally different. Practices are in a very challenging environment in terms of schedule, in terms of cost. It creates more barriers for a good educational experience. And so, not to mention the fact just financially, I think it's a drain sometimes on practices to slow down and be able to teach. There's a lot of emphasis on being as efficient as you can right now. So have y'all seen that as a problem as far as, and I'm talking to you, Rebecca, I'm sorry, but assigning or finding preceptors, and what are your barriers that you're seeing?
Yeah, I think that's true. And I think that's probably true from both the UME, so the medical student, as well as for residents to find. And I think that's true not only in our community, but across the country. That's something we talk about in terms of finding preceptors. And generally, I think pediatricians enjoy teaching. I think that's one of the things that, we enjoy. Obviously, we spend a lot of time teaching families and patients. So I think many of us are, the education is something we love to do, but I think there are barriers to it. And so finding practices and providers who are able to provide those opportunities for our learners has become an issue. Right. And it ties into giving experiences like Jessica had, but also to our students. And we know that all ties into, I think, part of the conversation we'll eventually have, but how we influence our students to want to go into pediatrics is to make sure they're having those experiences and that they can see the joy that we have when we're actually practicing, in addition to understanding how practices work. So there's a multitude of reasons that we need to have preceptors, but there are many challenges that are highlighted in that article in terms of the right. issues that come up with that.
Right. And some of that, is financial, obviously, but some of that is, I think there are certain preceptors now that don't feel comfortable in that teaching role. And so how do we go about creating an environment where they're comfortable as teachers and preceptors? Is that something that y'all have talked about?
Yeah, I think there's, I think providing, is it as easy as providing some faculty development? So right. some easy on-the-fly faculty development. It's always hard to know what the best way to deliver that is. Is it ways that we could do it over a lunchtime gathering where somebody comes in and provides that? There are CMEs that are virtual that they could join in, the things that are offered on the main campus that they could, participate in. There's not a one-size-fits-all to provide that, and certainly I think trying to figure out the best way to deliver that would be important. We've certainly have heard that is one of the things that some providers feel uncomfortable, that they don't know the best way to teach. On the other side of that, I think one of the ways that many of the learners will say that they've learned the most is really by watching what our providers do, that there is so much to be gained from the basics of communication skills and seeing how they examine children. And so some of it is not that the world has changed so much, it's that they just need the time with a provider to see how our provider provides care and works with a family. Right. There are some aspects that they need to understand in terms of the evaluation systems and those sorts of things, but many of our learners are just hungry to spend time with a provider taking care of families.
I think that's an excellent point because, and I don't know what your experience was, but I think there's so many students come in, and residents for that matter, want to come in and just say, let me see the patient and learn the skills and things like that. But to Rebecca's point, there's a lot to be learned by just watching someone who's done this and being in the corner and seeing how they interact and just basic skills of how to make children comfortable or how to address patients' concerns when they're very anxious, be it for vaccines or other things. And so those sorts of skills just by watching are things that can feed into you. And I don't know, did you experience that?
No, I couldn't agree more. Even I think in my last clinic, technically as a resident, I still would ask kind of the more experienced, seasoned attendings, there's always nuance with things, and how do I effectively explain this without being too scary, but also not oversimplifying it and kind of brushing it under the rug. I want to convey the importance of something, or how to more seamlessly do a physical exam thing like looking in ears. I feel like I could never get too much experience as far as like just seeing how different people do it, because can be chaotic every time. Yes. So yeah, even I think just the more observation and just kind of absorbing all of the expertise that people have built up over years of practice and trial and error has been invaluable, truly.
I was working with a student the other day. I was teaching pneumatic otoscopy. Have you learned that skill?
I wouldn't say I'm confident doing it myself, but I've seen it. Yes.
Yes, and it's something they're like, oh wow, that's really cool when you can get it just right and they can see that eardrum move. And the other part of this, and I'm going to jump ahead a little bit. I plan on talking about this later, but something that you get in the office that you can't really do inside a big system is learning how to run a practice too, especially this is more talking about residents and students, but if you're thinking about primary care, how do you know what insurance to bill? How do you bill? How do you get that money in? How do you get it to the bank? All those sorts of things. And when I had residents in my office, the setup is sometimes they would come out for several weeks at a time, if not over 6 months, on certain days. And I would have them actually spend time in the office, the billing office and things like that, so they could learn, even a check-in process and, how do you decide on an EMR and all those sorts of things. So there's a lot of things that, again, going back to the value of community preceptorships. And, obviously at CPF, we're trying to advocate hard for our members to continue to provide good precepting experiences. And we're trying to recruit more. And I think another great experience, I mentioned my experience being in a rural area. I mean, if we could find a way to get folks out into rural communities, there is a lot of great things to learn and see out there, and great teachers who are out there doing great things too. So I know it's difficult in today's environment. I can't get used to the fact that some people don't even have cars.
Yeah.
They come and they just, either bike or Uber. And it's like, there's a little bit being left on the table, I think, when it comes to that. But so I think this is all great stuff. And I want to kind of turn to the second article. And that was talking about residents in their program and their comfort level and preparedness to go into whatever, be it subspecialty or things like that. And this article came out also of Pediatrics in February of 2024, so a little bit older, but it looked at data over a period of, I believe it was close to 10 years, was it 2015, I believe, through the pandemic and into 2022. And they saw some interesting things. Most notably, the biggest declines in confidence were among those that wanted to enter primary care practice, and a confidence level that was at 68% fell to 42%. So I'm going to ask you, as you're getting ready to start in primary care, do you have any reservations, or tell me about what you felt like your training was like, and especially since you've been in a practice, do you feel walking in on day one, you're ready to go?
I mean, I think being a brand new graduate, I will not feel completely ready. Obviously, there's a lot that comes with time and experience. I think my continuity clinic experience was harder to get comfortable with at the beginning, just because it's something that we do maybe once a week, as opposed to a different rotation that you're on day in and day out, and you see kind of that comfortability build sooner. But I think towards the end of intern year and going into second and third year, I have become infinitely more comfortable in clinic. And since it is something that I'm going into, I think I put more time and effort into kind of streamlining my process and becoming more comfortable. It's a little bit also of kind of ignorance is bliss. It's starting out, you don't know what you don't know, and then you spend more time just experiencing all the different questions out of left field. I'm like, I have not even thought about that. Let me look into it. And there's just such a breadth of things that pediatricians just are on the front lines with, kind of fielding and deciphering what the next best step is. And so I think I'm trying to go into it with a mindset of, I don't have to know everything about everything. I need to know, I think, the bread and butter things, but also know what my resources are. So there's inevitably going to be things that I don't have the answers to, but knowing who to ask and where to look things up and continuing to develop kind of my knowledge over time rather than expecting myself to know everything day one, because that's just unrealistic.
That is incredibly wise. I think you are well suited and well prepared, because those are the sorts of things when they ask you, what do I do when my child keeps on buckling his car seat in the back? Those sorts of things. You're like,
yeah.
And yeah, you just know you've got your resources. You've got your partners, you've got CPF, you've got, people that you trained with that you can fall back on and ask those questions. Somebody asked me once, when did you feel comfortable with every aspect of your practice? And I told them honestly, I think it took me at least 10 years after I graduated to say that I was comfortable with it. You could throw anything at me and I knew. But there was a lot of humility and a lot of, just you relying on, like you said, your partners and all your resources. When I came out of residency training, I had a great job opportunity offered to me in Dallas, Texas, Richardson, just north of Dallas. And I thought this was perfect. My mother-in-law lived, 5-10 minutes from this practice. And this gentleman was wonderful. I walked around. I said, this is it. And he said, now, if you start, I'll hang around for a few months and then I'll head out the door. He was going to hand me the keys to his practice, and I was going to be in solo practice 3 months post-graduation. Can you imagine that?
Wow.
I ran. I ran as fast as I could because I really think, and looking back, I mean, again, to your point, there's a lot of learning to be done as you go. But I think your approach to it is wonderful, and things have changed a lot. I think when I came out, spinal taps and all those things, those were the things that you knew you were probably going to have to do, and circumcisions and procedural stuff. There was a lot more of that in treating illness. And now with behavioral health and things like that, it's a whole different ballgame. And maybe that has something to do with folks being less comfortable in primary care practice and what their exposures are. But again, I think that dovetails back into the first article, which is we really need to get them outside and experience everything possible, every environment of pediatrics, and support them in that way. Rebecca, do you have anything to add to that? Or
Yeah, I'm not necessarily surprised by this, to be totally honest. I think I was program director for 20 years before I took on this current role, and we have surveyed, and this data has been available every year, and so it's not uncommon for this information to come out. And until the recent changes to the residency program, I would say we often train people to be very good hospitalists because they spent so much time within inpatient world.
And that was my day.
Yeah,
right. Yeah.
For sure. And when you go to a fellowship, even if you're not ready to be a fellow, you still have supervisors, right? You're not on your own. So when you go into practice, and I always advise people, please don't go out in solo practice because you need mentorship. You're nervous because you don't know you both don't know what you don't know, and there's a lot of stuff out there that you don't know. We survey our graduates a year out, so just to see similar questions, but after they've been out there a year. So what did we not prepare you for? And most of the things are the things that you would expect that they say if they were in private practice. They wish they feel like they've learned a lot about development, the things that you can't learn doing once a week continuity clinic. They've learned a lot about development, about mental health, about the things that you just need to learn a lot, and the business of medicine, because it's the things you don't learn, because it's very challenging to teach, because if you're in the middle of a residency where there's so many other things that you have to learn, it's hard to find an engaging way to really teach that. And I was the same way when I was a resident way back when, the economics of healthcare were not the top intriguing lecture that I wanted to hear. So, but those have been very consistent on the feedback that we've gotten. So I do think the ACGME changes have helped so that there's more time in outpatient subspecialties, and they're trying to kind of pay more attention to mental health education and those sorts of things. But you're 100% correct that I think more time with community preceptors will hopefully help a little bit of that.
Well, I want to maybe hear a little bit more about the changes and the structure of programming, what we're doing, but specifically, I would say, what do you think is the right approach to teach more of the business part of the medicine? Is there a way inside the curriculum we do that, or do we leave that for our preceptors?
Well, I mean, Jessica can, chime in. I mean, I think there's some of it that's handled. So in our clinic setting, we do teach how you bill and think through, and so our residents are responsible for billing their own clinic visits. But it's within the spectrum of our patient population, which is majority Medicaid, so that you are learning to understand the basics of that. Right. But it doesn't delve into how you manage a business and the ins and outs of hiring, firing, looking through, getting approvals for things with different insurance plans and those kinds of things. We do a few prior auths and those kind of things, but not a significant amount of those things. We have a primary care interest group now, which is new in the last few years. And I think we've had a few speakers, from the community come in and talk about those kind of topics. I think that works better because it's a motivated group who have specific questions that will, when you're motivated and you have someone that's talking about it who lives it all the time, I think that helps. Mm-hmm. I think having speakers come and talk to the whole residency as a group over lunch has not been effective, just because it's just not effective. It's a mixed audience, and
you're just
people are distracted by other things. And
who has the best cookie in the box?
Yeah. So I don't think
that
hasn't worked well. So, and then I think going out into a primary care elective, I think, helps because you can sort of see it in action. So.
Well, we're trying to put together some structure here at CPF on whether it's lectures or things like that, some educational opportunities, because it's not just residents or even students. We're finding as we go in the community where a lot of practices are struggling, and that goes back to why a lot of practices are being purchased now, is there's a lot of people out there in practice still that need education. And I was just before we walked into the studio here was looking at the AAP national meeting that's coming up, and their practice management lectures and curriculum that's assigned. It's going to be excellent. So quick shout out for anybody listening. If you want to go to San Diego in October, it's going to be a great conference. So think about that. There's lots of things to be learned, plus a lot of networking. That's a lot. You can go into that meeting and meet a lot of people who can be mentors from afar even. So don't just limit yourself. The section of office and practice administration and office management it's only $35 a year. It's a great resource for pediatricians across the country that are doing these sorts of things. And I would recommend that to anybody in a heartbeat. But we've got lots of local pediatricians too that are interested in teaching business that we would love to kind of connect with everybody. But getting back to the other part of that, tell me a little bit about how the curriculum has changed and how we're addressing that.
So the ACGME in 2025 mandated, just to kind of keep the details kind of at a higher level, 2, I would say, significant changes. 1 was the implementation of behavioral health as a required curricular aspect. So, which I think is, for anyone who's currently practicing pediatrics, understands that it's got to be really a structured experience that's not just inpatient behavioral health, but inpatient and outpatient exposure to that. So that is one module or one curricular rotation that's been added. And the other is exposure early on to outpatient subspecialty experiences, which has been a nice adjunct to what we do, because I think especially for residency programs that are based in a tertiary care hospital like we are lucky to have in our community, it is very easy to train on mainly inpatient experiences, right? And then use electives with the elective time you have. And I think our residents get a fair amount of elective time, but then your electives are half a second year, essentially third year, you're kind of figuring out what you want to do. Well, this allows interns and to go to a variety of outpatient clinics in the subspecialty. So that's 2 things it does. One, it exposes you to them, which is nice for many of our subspecialties that are don't have a lot of interest. But it's also, if you're going to do primary care, you really see the aspects of the subspecialty that you really need to see. Right. So a great example is cardiology. We have fabulous cardiologists, but our inpatient cardiology experience is really specific. Those are very critically ill, complex children. And so we need to take advantage of our outpatient cardiology, which is fabulous. So I think that's for an example of one change that I think has been great.
You need to hear all those murmurs that you're going to hear in the exam room every day and say, oh, that's normal. I can tell you that's normal, and we can wait and watch and all those sorts of things. So, I think that's wonderful. So, and, the other thing I think we wanted to go on to is the last article that we had talked about. This is factors that influence medical students' career choice into going into pediatrics. Because again, as we need to recruit more pediatricians, I think it's an interesting look at why people are not choosing pediatrics. Couple of things that I took away, and they looked at, by the way, this was a group, I should mention, this came out of the Journal of Pediatrics in February of 2024. Again, it was titled Factors Influencing Medical Students' Career Choice to Pursue Pediatrics. And when they did a study, and they were able to get 426 respondents, and these were fourth-year medical students, I believe, that had gone through the process of the interviews, but had not yet gone through the match process. So it was a questionnaire, and 15% of those had chosen pediatrics. 40% had considered pediatrics but chosen another field, and then 45% were like, no way am I doing pediatrics. A couple of interesting things. 42% of people who chose pediatrics knew before they even started it was like a chosen, like I want to be a pediatrician. And I don't know if you see that necessarily in any other field. In fact, I think it was 22% who considered pediatrics and then switched to something else, and 9% of those 22% who never considered pediatrics, 9% who switched. But they looked at a lot of the barriers of that. And not surprisingly, I should say, is a large number of people who chose to go away from pediatrics mention earnings potential. And, that is not shocking to probably anybody who's listening to this podcast, is that we are not the wealthiest doctors on the block. But we knew that going in, right? And so, but I think the other thing that shocked me was almost, I don't think I have the exact number in front of me, but almost half of those graduating now have $200,000 in debt. Yeah. And so I think that is a significant barrier. And so, now we're getting into the world of politics and everything else that goes with that. But I'll just go back and tell you that the years that we had Medicare parity for Medicaid payments were some of the best times that pediatricians had. I mean, you felt valued, your payments were up. But now those payments, especially for Medicaid, which is such a big part of it, especially a new pediatric practice, doesn't exist. But the other factor besides payment, which is more difficult to deal with, people who chose pediatrics were heavily influenced by mentorship. Okay. And so I'm going to turn to you, Jesse, and say, first of all, were you one of the 42% that knew you were going to be a pediatrician from the get-go?
I was.
Okay.
Yes.
So what influenced you?
Drawn. I can't even necessarily put my finger on it. I just knew, I think even, before medical school, and actually before medical school, I was a behavioral therapist for kids with autism, and I knew that I enjoyed working with children, and I think it's just the joy and just being at the pediatrics hospital is, to me, infinitely better than being at the adult hospital. I can't even explain it. The color, the kind of emotions, I know it's a difficult time, especially if you're in the hospital and whatnot. But I don't know. I think so many pediatricians that are drawn to the field have the similar sense of just wanting to work with kids, knowing that they want to work with this population from early on. And it's so interesting. My husband, who's also in medicine, he knew off the bat that he did not want to work with children. Yeah. It's just that inherent, you either kind of know or not for a lot of people, and choose to go into pediatrics despite maybe making less than another specialty or whatnot. I will say I was part of the percentage that knew early on. And
you said you were behavioral.
I was a behavioral therapist, so for kids with autism, doing like ABA therapy.
Did you have a graduate degree in that before you went back to medical school? Or
not at that time. No, I got my graduate degree after.
Okay. All right, that's outstanding. So again, it goes back to those exposures that mold you, and again, that goes back to, I think, having the examples laid out before you, which we've got to continue to make sure we provide those early exposures. And speaking of that, we had a great kind of change this year at Vanderbilt, or development at Vanderbilt, I guess we'd say. It was 2025, actually, I think, when the undergraduates at Vanderbilt started the Vanderbilt Pediatric Association. Is that how? Yeah. So, and I think you were involved in helping set that up, and I've worked with one of the co-founders there and mentored a little bit. And tell me a little bit. Did they come to you with this idea?
So Vanderbilt University certainly has pre-med advising, and this was a group at the same time that we were trying to, at a department level, work on some other efforts to increase opportunities for high school students in the community to get involved in research and shadowing, just to increase interest in healthcare. Sort of across the board. I'm involved in some other ways. There's a pre-med book club, and there's some other things that go on at Vanderbilt. But they came to us and said they wanted to start a Vanderbilt Pediatric Association. And so to Daisy Senior, who is the Peds Emergency Medicine Fellowship Program Director, and Devang Pastaki, who's one of the Associate Program Directors for the residency program. So the three of us worked with them to work on getting it approved as an official organization at Vanderbilt. And they have been phenomenal at kind of organizing to do both service in the community, which has been great. They've worked with a local elementary school doing some service activities, getting a variety of people to do presentations on a variety of career opportunities, everything from pediatric surgeons to child life to other ancillary services and sort of peds adjacent things, to just kind of broadly speaking. They've had fellows and residents come do panels. They've been very active. And most recently, they connected with the AAP and actually have developed a toolkit so other universities can develop it. And most recently, Duke University has actually developed their own, I don't know what they're calling it, Duke Pediatric Association, which may not be what they're calling it, but the same sort of activity, which is
glad
great.
to see that Duke's finally recognizing that Vanderbilt is the leader in the field. So.
Yes, exactly. So I think that's great, because I think that when in that article they were talking about modifiable factors to increase interest, and I think that the politics of changing reimbursement is, I'm going to go out and say, is probably outside the scope of this table. But things of helping increase exposure, both at the university and before, increasing exposure in the early years of medical school, those are things, and in the clerkship are things that we can definitely make effort with. Right. So that's a great place that, increasing mentorship and preceptorship can make a difference.
I will agree with you. It's outside the scope that we can change it, but it doesn't mean we can't talk about it.
Oh,
because
absolutely.
I think that, we tend to be nice people as pediatricians. We don't like to be confrontational much of the time, but I think at some point we have to say the future of child health is important and it should be valued. And I think we need to continue saying that over and over again.
Well, and I will clarify
that
is that we need to work with the organizations that we belong to who are advocating for that. So whether that's, say, AAP, organizations through medical education that I work with, who are all helping us advocate for it. So
and network
yes.
with your, know who your politicians and representatives are, and maybe they listen, maybe they don't, but
the more they hear from us, the more it matters, I think. So
absolutely. And again, it goes back to experiences, and I wouldn't be here today if it weren't for the experiences I was given, even going back to college. Had a chance to volunteer at a hospital, but more importantly, I had an opportunity to be an intern chaplain at a hospital, which was fascinating. And I didn't know what to make of it, but as one of the preceptors said, this gets you over the fear of walking in and what's on the other side of the door. And it really did. You learned everyone has a story and everyone has a different background. And I think that was probably laid the groundwork for me going into primary care, because it's like, oh, there's more than just what's in the textbook. And you start to learn how important, and again, that goes into, ACEs and trauma-based care and things like that. All the sorts of things that we have names for now. Back then, we were just saying it's your story. And I think that's, it's important that we get in front of these students and get in front of the people and show them that what we do is very valuable. And, every pediatrician can tell you a story like this, but, I've been out of full-time clinical practice for a few years now, but ran into a patient while I was shopping. And, of course, we swapped stories. It was good to see him, got a couple of hugs, but she finally almost kind of did bring me to tears when she said, you don't know the difference you made when I had those two young kids. She said, I was... I didn't know what to do, and you were so helpful in walking me through it. And, I told my children, I said, we may not get the notoriety or the respect or whatever you want to call it. We definitely don't get the money, but I will walk out of this one day and know that I helped people and I made a difference, and that's all I can ask. And so I think the same goes for when we talk about all these issues about medical education. Is people did it for us and laid the groundwork for us, and we need to kind of make sure that we're laying the groundwork for them, because I think the health of everyone in Tennessee and across the country depends on it. So I appreciate y'all sitting down to talk about this. Any closing comments that you wanted to make, Jesse?
No, I just agree wholeheartedly. I similarly kind of reflect back on my mentors, and early on in medical school, getting the exposure I think was crucial, because not everybody had the opportunity, at least in my med school, to do specifically pediatric primary care as their continuity clinic one, and it was kind of a lottery system. So I was lucky enough to be able to do one of the pediatrics ones, just because there was a lack of pediatric preceptors even.
Right.
So yeah, that exposure is just of the utmost importance. And similarly to you, I recently had an encounter with a family that just really expressed a lot of appreciation. And it was a little bit sad when I was saying I was graduating and moving to a different clinic, and they were like, what's the clinic? I want to come. And you have been just amazing for my kids here. And I was able to at least tell them that I was staying in Nashville. So if they wanted to come, they were more than welcome to. And so we do it for the families, for the children, for these experiences. And even if the money is not as much of a draw as other fields, I think it's necessary, and it's really worth it, even in the end.
I wouldn't change a thing about what I've done. So,
Yeah.
Rebecca, do you want to close with anything?
Well, I think that the role of a mentor and a preceptor cannot be, de-emphasized. I mean, I think, and that there's not really specific training that we can provide whatever people need, but I just think the presence of someone who's walking that walk, just showing a student and a trainee what that looks like and how much you enjoy what you do, means more than people really realize. You don't have to be super trained in special skills. It's really just allowing someone to see you in doing what you're doing and how you interact with families. And whatever we can provide, I'd love to, work with you and CPF to see what we can do to help that, because we know it really does matter. The earlier a student can see what pediatrics looks like, the better we have the chance of overcoming some of these other things, so they can see what a joy it really is to do what we do.
Absolutely. And so, for those of you listening, watching, we would love to talk to you about the opportunity to be a preceptor, or how you can get involved, or if you want to and you are facing some of those challenges we talked about, talk to us about that too, because we certainly want to have those discussions here. We want to have those discussions at Vanderbilt, so we can continue to produce the quality of pediatricians and the people that will enjoy this career. And like I said, change the lives of people throughout the state. So thank you for listening. And if you have any questions about this episode or something you want to hear in future episodes, I always say reach out to us at cpfnashville@gmail.com. Your email will be forwarded to the right person, and we're happy to talk to you and correspond with you. So thank you again for listening and being with us. And until next time, take care.
Thank you for joining Cumberland Conversations. We're proud to support the people who care for Tennessee's children. Don't forget to subscribe so you never miss an episode, and stay connected with CPF for more tools, trainings, and community updates. Until next time, take care.